It's 2 a.m. on your ICU night shift, and suddenly the alarms on bed 4 start screaming. You literally have 6 seconds before a thrashing, severely agitated patient pulls their endotracheal tube. Your heart rate spikes. Today, we're jumping right into a high-stakes clinical simulation to master non-pharmacological agitation management.
Section 1. The Bed 4 Crisis. So looking at Bed 4, this patient's agitation isn't just some physical struggle. It's like a dense, disorienting fog rolling right into the intricate clockwork of their mind. The tension in that room is absolutely palpable. We have to prevent a catastrophic self-extubation or a major physical injury. The clinical decisions you make in these next few seconds are going to dictate whether this patient safely stabilizes or spirals into some serious life-threatening complications.
To resolve this crisis effectively, we are going to directly address 2 highly practical, clinically compelling questions. First, we need to know which specific environmental adjustments actually prevent patient self-harm better than standard physical restraints. Second, we will look at how you can deploy family members as an active de-escalation intervention, rather than just viewing them as a liability on the ward. Now, the evidence and protocols we are using for this simulation come straight from the Calm ICU Clinical Practice Guideline. This was published in the journal Australian Critical Care in 2026. And as always, the links to the bibliography are in the description below.
Section 2. Investigate the underlying causes.
Okay, when you're facing that dense fog of patient agitation, the initial instinct is often blunt force sedation. But we have to shift away from that and initiate a methodical investigation instead. Step 1 is getting an early assessment right upon ICU admission. Step 2 mandates regular, consistent screening using validated tools like the RASS scale every 8 to 12 hours. And Step 3 is all about identifying the specific triggers. We need to figure out exactly what's going on, specifically looking for hypoxia, pain, withdrawal, or maybe an unmet fundamental care need. Finding that exact broken gear in the patient's mental clockwork is absolutely essential. This brings us to a highly effective mental model that you can use in your daily practice. I really want you to memorize this and share it with your colleagues on the ward. Investigate the cause, calibrate the room before you medicate the mind. Following this exact sequence completely changes the trajectory of patient care and safety in the ICU.
Section 3. Calibrate the patient environment. Think of the patient's sensory experience in a chaotic ICU as this overwhelming, disorienting darkness. Our main goal is to bring warm, orienting light back into that space. Now, traditional pharmacological sedation and physical restraints can actually paradoxically make agitation worse. They act like rusty iron bindings that just induce panic and further trauma. But precise, non-pharmacological sensory calibration actively treats the root cause without carrying the severe risks of prolonged mechanical ventilation.
So, what does that calibration look like? Think of these environmental adjustments as those flickering gas lamps that help reorient the patient. You want to group your care activities together to avoid constantly waking them up. Definitely minimize routine, non-critical nighttime interventions, like unnecessary glucose monitoring. Optimize the room temperature and strictly support their natural circadian rhythms by keeping the noise level low. Modifying these sensory inputs is an incredibly powerful clinical intervention.
Section 4. Deploy multi-component non-pharmacological care.
We also need to deploy active therapeutic interventions to provide genuine alternatives to chemical restraints, and we do this through a proven multi-component strategy. First up is reorientation. Make sure clocks are clearly visible and that the patient has their personal hearing aids or visual aids. Second is comfort. Believe it or not, offering a simple fidget toy can be super effective at distracting from restlessness. Third is music therapy. Playing relaxing, tailored acoustic music actually yields a proven reduction in agitation severity. And finally, early mobilization. Just helping a patient sit up with their feet flat on the floor provides a profound grounding effect and promotes natural tiredness. And you know, these strategies have a highly rigorous foundation. They're based on a modified Delphi study that involved 114 experts across Denmark and Australia. So these practices are backed by strong expert consensus, proving their clinical feasibility, safety, and really high value for your patients.
Section 5. Enlist family as clinical allies.
Moving to our second compelling question, let's talk about the strategic deployment of the patient's family. Relatives are often seen as just passive observers or even a liability, but we can completely transform them into active clinical partners. First, assess their capability and willingness to get involved. Then, provide them with clear, straightforward information about ICU agitation. Teach them specific, non-pharmacological de-escalation strategies. Because family members actually know the patient's baseline and routines, enlisting them creates an incredibly powerful alliance in safely de-escalating distress. And if physical visits are impossible, absolutely facilitate phone or video meetings. Section 6. Action plan and summary. All right, as our clinical simulation at Bed 4 finally stabilizes, it's time to bring your shift to a successful close. Here are your 3 key clinically actionable points from this explainer. Number 1, implement multi-component non-pharmacological strategies like targeted music and early mobilization first before automatically reaching for medication. Number 2, reorient the patient by utilizing situation-oriented communication and getting the family actively involved to restore their awareness of their surroundings.
And number 3, adjust the ward stimuli by strictly minimizing routine nighttime interventions and standardizing a calm sleep environment. So, here is your call to action. Take these calm ICU principles and implement them on your very next shift. And remember to share the mnemonic with your attending. Investigate the cause, calibrate the room, before you medicate the mind. By changing our approach, we fundamentally improve patient safety. Just think about the massive impact here. Preventing even a single catastrophic extubation tonight using these non-pharmacological shifts could literally save your unit countless days of mechanical ventilation this year. Disclaimer and bibliography in the description.